Uh, it's an honor for me to have a speech here today. Today I would like to talk about the topic of valve fracture. Is it mandatory in ViV TAVI? ViV TAVI has proven to be a safe and effective treatment for patients with failed surgical valves, and the use of ViV procedure is increasing. Elevated residual transvalvular gradients may occur following ViV TAVI, particularly in the presence of a small bioprosthesis with a label size of 21 millimeter and under. In previous data, the smaller the initial surgical valve, the higher the mortality after ViV TAVI was observed. Novel techniques such as bioprosthetic valve fracture has been explored to address these issues. Valve fracture increases the internal dimensions of the surgical valve, improving expansion of the TAVI valve. After successful valve fracture, residual vascular gradients can reduce and effective orifice area can increase. Therefore, for optimal TAVI, in cases anticipating PPM, valve fracture should be done at the time of TAVI implantation. Well, luckily, most surgical valves can be fractured, and we usually need non-compliant balloons such as Atlas Gold. Initial step for high-pressure balloon inflation consists of a large syringe, inflator, and a high-pressure stopcock. Successful valve fracture is characterized by a sudden drop in the pressure on the inflator gauge and often accompanied an audible snap. For the proper balloon sizing, you should understand the valve anatomy, particularly when performing valve fracture after implanting a self-expandable valve. The valve has a narrowed area known as the constrained area. When using a high-pressure balloon larger than the diameter of the constrained area, trauma and valvular insufficiency can be occurred. Therefore, to minimize the chance of trauma, balloon size should not be larger than the constrained area, and to minimize the risk of tearing the leaflet, we keep the superior shoulder of the balloon below the constrained area. Then, when do you think is the right timing to do valve fracture? Before or after TAVI? When you do valve fracture before TAVI, high pressure inflation of TAVI processes is not necessary. However, the risk for embolization or severe AR can be raised. Maybe in that case, sentinel protection and rapid TAVI implantation would be required. On the other hand, when you do valve fracture after valve, the high pressure inflation ensures optimal expansion of TAVI processes. However, it also can lead acute injury to the valve and leaflet. A prior bench test report observed the impact of valve fracture timing on valve durability using accelerated wear testing and microscopic and histologic analysis. Sapien 3 and Accurate Neo were implanted to mitral flow surgical valve in 3 experimental setups. The hydrodynamic testing with 200 million cycles, which is equivalent to 5 years, were done. From the result, a valve fracture performed after valve was associated with a larger UA without increase in regurgitant fraction. After showed better than before here. From the histological analysis, valve fracture after valve is associated with more superficial damage. However, from the whole leaflet thickness analysis, ultrastructure was preserved. Then, how about the clinical outcomes after balloon fracture? Would clinical outcomes be different according to the timing of valve fracture? Let's see the recent publication. From the data of STS-ACC TVT registry, among a total of 2,900 valve cases, 21% underwent balloon valve fracture. From the safety outcomes, the attempted bioprocess valve fracture was associated with increased risk for in-hospital mortality. Valve fracture before valve-in-valve was also associated with increased mortality and no change in hemodynamic parameters, whereas valve fracture after valve-in-valve was associated with similar mortality and improved hemodynamic status. From this result, I would like to say that valve fracture after valve-in-valve is recommended. However, valve fracture before valve-in-valve need to be concerned. Then, what are the complications of valve fracture? How to overcome them? Here are the summary of complications following valve fracture: stroke, pacemaker insertion, severe AR, mitral valve damage, coronary occlusion, VSD, annular rupture, and among them, I think the most terrific event would be coronary artery occlusion. In this coronary angiogram, you can see a very low left main in relation to mitral flow surgical valve with chimney root and no coronary sinuses into which the fractured valve can expand, which can increase the chance of coronary occlusion. Then how to overcome it? Now we can apply basilica and chimney stenting. There was a report compared two techniques at EuroPCR 2023 in Paris. Chimney stenting is a widely used technique to prevent TAVI-related coronary occlusion in patients at high clinical risk. You can see the stent deployment with generous protrusion like this figure. Here is our case who applied chimney stenting. The patient was 87 female, accompanied persistent AFib. From the CT analysis, a bridged calcification observed, and left coronary height was only 4 millimeter. And 3-mensio virtual planning warned coronary obstruction risk. In addition, we have been applied this virtual pre-procedure planning by our own 3D viewer as well. This virtual planning offers us intuitive insights about the risk of coronary obstruction. When we insert the valve, we see that there is a risk that the native leaflet here is pushed toward the left main ostium and blocking the blood flow into the opening. So we decided to use SAPIEN valve for easy chimney stenting. LCA protection with guideliner was done. We performed the pre-dilation first with a 60 millimeter balloon. You can see that during ballooning, native leaflet is blocking the blood flow. We performed TAVI and coronary stenting concomitantly using chimney stenting technique for this case. This is the final angiogram after chimney stenting and post-NC balloon. Let's get back to the EuroPCR reports. And even though the worst anatomical setting observed by CT in the basilica group, technical success rate was comparable, and minor bleeding and PVL were more occurred in chimney stent group. There was no difference of MACE incidence between two groups, but numerically higher CV mortality with chimney stenting was observed. The patient, here is our case of basilica. The patient was 82-year-old female who have AVR, TVR, and pacemaker insertion, AFib, CKD, and perimeter-derived diameter was only 17, and left coronary artery height was only 6.5 millimeter. The implanted surgical valve has a spec of 11 millimeter height. Therefore, if we put the Evolute R-TAVI valve inside the surgical mitral flow, the chance of left coronary occlusion is expected. We planned basilica before valve-in-valve TAVI, sentinel for embolism protection, and valve fracture for the optimization. So sentinel was placed, and basilica. And for basilica, we set up the snaring and traversal system. For setup of traversal system, through short AL guiding catheter, Davis neuroangio catheter, and fine cross and astato electrified wire was sequentially placed. The electrifiable astato was connected to the bobby at its end and penetrating the degenerative surgical valves. The wire targeted the nadir of surgical valve leaflet and was snared and then externalized through the MP catheter system. The half portion of astato wire was previously decoded and made V-shaped in advance. The V-shaped portion was positioned at the target leaflet. Then, by pulling the electrified wire on both outer ends, the leaflet was split from bottom to tip. After successful basilica, Evoludal 23mm valve was smoothly implanted, and valve fracture was performed by using Atlas Gold 20mm up to burst pressure. You can see the widening. After valve fracture, we confirmed no complication and good coronary flow, and the retrieval of sentinel device showed embolic tissue material from the left side filter. Post-TAVI echo showed well-expanded round-shaped TAVI valve and Vmax reduced. So we successfully performed valve-in-valve TAVI in a patient with failed surgical valve. In this case, we used the sentinel device, performed basilica, TAVI, and valve fracture. So, ladies and gentlemen, here is my take-home message. In cases anticipating patient PPM, bioprosthetic valve fracture should be done at the time of TAVI implantation. And the timing of valve fracture is important. From the recent registry data, valve fracture attempted prior to valve-in-valve was associated with increased mortality, whereas the valve fracture after valve-in-valve was associated with similar mortality and improved hemodynamic status. Another recent data comparing chimney with basilica showed that chimney stenting was associated with a higher risk of complications. And for an optimal valve-in-valve TAVI, operators should be familiar to the technique of basilica and valve fracture as well, I think. Thank you for your attention.